to Dr. Swanson. Thanks for being here.
Okay. Thank you, Natasha. Thank you for setting this up. And thank you, everybody that's joining. I know it's a nice, lovely day outside, and so we'll try to make this quick so we can go and enjoy our little Tahoe summer. Just a little bit of background about myself. Most of you know that I grew up here, graduated from South Tahoe High in 1989, went on and did my medical school and college out in Texas, and then did my orthopedic training program or residency in San Francisco. I did what we call the HPSP scholarship, which is a health profession scholarship program through the military, which paid for my medical school. And so I served on active duty in the medical corps from '04 to '07. And then came back here, did the sports medicine fellowship that we have here at Barden in '08, and then joined the group in 2008. So it's been quite a journey, and it's hard to believe it's already been almost 18 years now since I've been practicing out here in Tahoe. I was on the US ski team as one of the physician that covers their teams, and currently am a faculty member for our sports medicine fellowship program here in Tahoe, and also work with medical students from UNR. Currently, I'm the director of orthopedics at Barden and chief of surgery. So our objective tonight is really, I think it's important to understand, anatomy, so that can help with as far as understanding what kind of treatments are out there, understanding a little bit about what arthritis is, and then backgrounds on partial knee replacements, and then who's a candidate, and then what to expect if you end up having this procedure. So the knee is a complex joint. It's not really just a hinge, but it also rotates and translates. And some of the more important structures in the knee is what we call, as we all know, the meniscus, which really acts as the shock absorber. There's two of them. There's what we call a medial, which is on the inside part of the knee, and a lateral, which is on the outside. Now, the meniscus is strong as far as absorbing shocks and different loads, but it's poor at healing. It doesn't have really good healing capacity. And so if you do get a tear, the healing doesn't really occur. Um, it also acts as a secondary stabilizer. And then we have ligaments which surround the knee, as well as there's a couple of major ones inside the knee. The one that's most common is obviously the ACL. And these ligaments are there to provide stability for the knee. And then cartilage, if you think about it, is actually the smooth coating that covers the ends of the bones. Um, and unfortunately, cartilage has really no healing capacity. So when you get an injury to the cartilage, that can actually be the start of the process of arthritis. And so the function of the knee is really a modified hinge joint, but it's not just flexion and extension, but also there's rotation and translation, as we talked about. It is the largest joint in the body, and it's really a weight-bearing joint. It takes a lot of load on it, and just walking, actually 3 times your body weight goes across the joint, and with running, it's 6 times the body weight. The patella, which is the kneecap, acts as a fulcrum and allows you to increase your power through the leg. So, what is arthritis? In general terms, all arthritis is the breakdown or loss of cartilage. And as I said, cartilage does not have any kind of healing capacity. And so when you do get an injury or when it does break down, the cells, which are called chondrocytes, do not regenerate that matrix. Um, and over time, that cartilage small deficits or focal defects can spread and involve the whole joint. There's many causes. It can be genetics, it can be autoimmune disorders, traumatic, and then it can just be idiopathic where we don't know what can cause it. But if you look here at the stages, stage one is really in this knee. You don't really see any significant damage, but there's on the microscopic level, you can start to see some breakdown of cartilage. And then as we get to what we call stage two or stage three, you start to see some even full thickness areas of focal defects in the cartilage. And then over time, that becomes basically pretty involved as far as involving the whole joint. And arthritis doesn't just affect the cartilage, it also affects the ligaments, the meniscus, and the other surrounding structures of that joint. And once the process begins, it's irreversible. We don't have anything right now in our capabilities to stop or even regenerate cartilage. There's different things that are out there that have been advertised, but in reality, we don't have anything, one thing that we can do to stop the process of arthritis and then actually start to grow the cartilage back. And this is what it looks like on an X-ray, as you can see on this. I don't know if my pointer, yeah. So if you can see on this X-ray, this is what a normal knee looks like. What we're looking for on these weight-bearing films is how much space is in between the bones. That's not air that's between the bones. What that is shows you the thickness of the cartilage that is in place. And as you can see on this X-ray to the left, there is loss of that joint space, and that indicates loss of cartilage. And so that's what we're looking for when we're taking X-rays. And then this is just a schematic of what we're looking at. This is obviously on this left schematic is a normal knee with a normal space. And on the right, we see that loss of space and that loss of cartilage. So partial knee replacements, or what we call unicompartmental knee replacements, they've actually been around for quite some time. That first one was done back in the 1940s by Dr. Campbell. And that's the Dr. Campbell that you may have heard of as far as for the Campbell Clinic out in Tennessee. The problem is the designs had a really high failure rate. There was early loosening of the implants, and the materials were not strong, and so you get breakage of the materials. As you can see here, this is one of the early partial knee replacements. It's not even fixed. It's actually a mobile bearing type of device. These are some of the older ones as well. This one that I'm pointing to on the top left and then bottom right. And you can see that there's significant gapping and wearing in these implants. And actually on the tibial side, this is the tibia here, there's not even a metal component. It's actually a plastic component that's cemented in. And these plastic components that were just all poly components had very high failure rates because of just, they were not strong materials. And then down here on the bottom left, this is what we're using in today's world. Metal on the femur, metal on the tibia, and then a plastic bearing that's in between. And so as you can imagine, as time has gone on, the technology has improved both in the materials, the surgical technique, and also the indications. And nowadays, as we get further into the future, we're using robotic surgery to help with assist us during these procedures. And then a lot of questions that people have is, well, what is the difference between a partial knee replacement versus a total knee replacement? Well, partial knee replacement is just only replacing the part that is affected. And if we look at the knee joint, there's actually three compartments to it. There's what we call the medial compartment, which is the inside part of the knee. There's the lateral compartment, which is the outside part of the knee. And then there's the patellofemoral joint, which is underneath the kneecap. You can actually replace any one of those three individual compartments on its own. And so the partial knee is nice because we only really replace the part that's affected. One thing that's an advantage is we preserve the ligaments that are surrounding the knee as well as the ligaments inside the knee. And the main ligament that we preserve is the ACL. Now, the ACL is not only important for stability, but it's also important for what we call proprioception, or actually knowing where the knee is in space with reference to that interconnection between the brain and your joint. And so like patients that have a total knee, we cut out the ACL, and a lot of their complaints are the knee doesn't really feel like their knee. It feels foreign. And that's because we have taken out those structures that provide that feedback to the brain. And as you can imagine, if you're only replacing one part of the knee, it's less invasive, it's less surgical trauma, and then the recovery is typically faster and less complications. And so this is just looking at what a partial knee looks like versus a total knee. So on your right over here is a total knee. And as you can see, we've resected out the whole femur on the end of it and the whole tibia and replaced it with metal and plastic. And the ligaments, especially the ACLs, right here in the center, that is also cut out or not preserved. And this is what it looks like on a kind of schematic. This is the metal covering the whole femur and the tibia covering the whole tibia. And then as you can see, this big plastic bearing with none of the ligaments. Now on the left over here, this is an X-ray of what a partial knee looks like. And as you can see, the lateral compartment is still preserved, and underneath the kneecap is still preserved. And then the schematic again, you can see the ligaments, especially the ACL, we keep that intact. So what are signs and symptoms really for knee arthritis? There's really, it's kind of what you would expect, pain, but it's not a sharp pain. It's usually a slow, kind of progressive, dull ache that starts to kind of show itself over time. Obviously, the pain can increase with activities, but a lot of times people have more pain after activities. And then there's the morning pain. Actually, first thing in the morning, patients or people will wake up with morning pain and stiffness, and that's more symptomatic of arthritis. People notice that stiffness again in the morning, but also with prolonged sitting. If you sit for a long period of time, you go to stand up, your knee feels like it's either stuck or locked or it's painful. And then these other signs such as swelling and then the popping and grinding. And that popping and grinding is what's occurring is you don't have that smooth articulation between the two bones because of the cartilage breakdown. And so you get this roughened surface, and that causes that kind of grating or grinding type of sensation. And then the swelling is just a result of the arthritis. It's really inflammation that's occurring because the joint is not working as it should. And so you don't get that smooth articulation, and it causes this inflammatory response. And so people always go, when do you go to the doctor? I mean, do you go for every kind of knee pain? And typically not. If you don't have an injury, I always tell patients that, give it a month. I mean, if it's a new onset of pain, that's a dull ache, and you don't have a traumatic event, it might just be that you've overdone something, you overdid it, and the knee is just responding. So I usually say take a month to kind of see how it responds. If the pain worsens and not responding to things like over-the-counter medications like an anti-inflammatory or just resting or icing, you start to notice losing or loss of motion. And then certainly obviously persistent swelling and loss of or decrease in exercise tolerance. Then I think at that point, it's certainly reasonable to consider going and seeing a physician. And you can even start with seeing your primary care provider. The question is, who's a candidate for partial knee replacement? Well, it used to be very specific and very, um, you know, you know, focal as far as the patients that would be candidates for it. That's kind of changed over the last, I'd say 5 to 10 years. And the most recent example is Lindsey Vaughn. She had a partial knee replacement. It was done by robotic surgery as well, and she replaced her outside compartment, the lateral compartment, and was able to go back to obviously a very high level, high function. And then, unfortunately, when she crashed in her Olympic bid, she didn't actually injure the knee that had the replacement. She actually injured her other knee that ended up requiring surgery. Um, but in general, patients that have arthritis that's really confined to the one of the three compartments, that's not diffuse, that pain should be localized to that compartment as well. Um, with patients that I see, if they come in and their arthritis is really to one compartment, but their pain is all over, I'm a little hesitant to see if they're or say that they're a candidate for a partial knee replacement, just because sometimes other things can be going on that can be causing that pain in the knee as well. What we call correctable deformities, which means that we can correct the deformity. It's not severe enough where we can't correct it when we do the surgery. And then, of course, intact ligaments. The major one that we think that the major one that's important for being intact is the ACL because it provides that anterior stability. And then we want good range of motion. And then, of course, obviously, patients that have failed conservative treatment. Typically, a lot of patients with new onset arthritic symptoms can be treated without surgery. It can be with physical therapy, just working on a strengthening program, anti-inflammatories to try to decrease that pain and inflammation, and then just a stretching program to really stretch out the ligaments and muscles around the joint. So who are patients that are not really candidates for partial knee replacements? As you would expect, arthritis that's affecting all three compartments. Um, some of the more inflammatory arthritis, like rheumatoid arthritic patients, or these other inflammatory arthritis patients, are not really candidates because that that those kind of conditions affect the whole joint, even though maybe one of the parts of the joint only has the cartilage affected on that compartment. It's more of a systemic disease, and it affects the whole joint and the soft tissues around that joint. Patients that don't have really good motion are really not candidates. And then, as I said before, ligament deficiency, especially the ACL, those patients are not candidates. Now, I have done surgery on patients that don't have an ACL, but they only have isolated arthritis in in one compartment. When I've done where you can do what you call a combined procedure, where you actually do the ACL surgery as well as doing the partial knee replacement. And then large fixed deformities. Patients that have really significant deformed knees, it's hard to correct those with just doing a partial knee replacement, and we have to do more invasive type of procedures to correct for the limb deformity. Studies that we get, really the x-rays can kind of tell a lot, and like as you can see on this x-ray here, we can look and see, what we're looking for is how much joint space that's still left, how much deformity there is on the alignment films. And then we might want to get an MRI if we're questioning about what the ligament is, especially if the ACL, if we're not really convinced that the ACL is intact. An MRI gives us that information about if the ligament's intact or not. And then also gives us a better understanding of the cartilage status in the other compartments. And then we typically would get a CT scan. We do need to get CT scans if we're going to do robotic surgery using the Makoplasty, but that also gives us a good three-dimensional picture of that knee joint as well. So what is Mako robotic assisted partial knee replacement? Well, in general, what is Mako robotics? And Makoplasty actually has been around for almost 20 years now. It actually did first start with just partial knee replacements, and then it's expanded to total knees and hip replacements. And then soon it's going to be in the shoulders as well. And it doesn't do the robot doesn't actually do the surgery. The surgeon actually has the hand on the trigger the whole time. And it really is assisting the surgeon in making the cuts and planning for the surgery. The CT scan creates a three-dimensional model of the patient's knee, and it's specific for the patient. And what that allows us to do is to do preoperative planning on that CT scan to be able to put in the exact size that we want, also to balance the knee, and then also put the position of the implants. And as you can see here in this is the robotic arm here, the Makoplasty. But if you look down here in this picture down low, this is the surgeon here doing the procedure with the robotic arm, making the cuts. And looking at the video here, or the diagram of the CT scan of the knee, and it shows us where we're making those cuts. And what it has involved is what we call haptics, where it will not allow us to cut outside what you see on the green here, the way it is device or plan. It doesn't allow us to go outside the green. And so we can make precise cuts and take minimal amount of bone resections and preserve bone. And so it's pretty amazing. It's less invasive because we can make smaller incisions and use instruments that are smaller to get into those areas. The advantages, like I said, is more precise bone cuts. It can cut down to 0.5 millimeters. That's how precise it can get. And then we can get the positions of the implants exactly how we want it based on the patient's knee anatomy. Smaller incisions because we're using more precise instrumentations that does not require larger incisions. And again, we're preserving healthy bone and ligaments by taking less cuts. And doing all that, typically patients do have less postoperative pain. So kind of just a rundown, let's say you're a candidate for surgery and you want to go to surgery. What's kind of the process? Once surgery has been decided, surgery gets scheduled, and typically we're booking surgeries typically 6 weeks in advance. That's on average. It's harder to get in sooner because there's a lot of preoperative planning that needs to go into it. We do have at Barden, we have total joint navigators that once the surgery has been scheduled, they will actually reach out to the patient and contact them and kind of lay what the process is going forward. And that begins with a preoperative workup by the anesthesia team. And they do sometimes when you require blood work, EKGs, everything's kind of tailored towards what the patient's comorbidities are. And then there is a total joint class that the patient can go to. It's typically online, and it talks more about the surgery, about what to expect. Um, and then typically, at least in my practice, I have the patient come in and see me with either myself or a PA about a week to 2 weeks before surgery. That's to go over any last minute questions that the patient may have, make sure that all the preoperative workup, there's no abnormalities that need to be corrected. And then also getting the patient set up with their postoperative medications that they're going to need. The day of surgery, typically patients will arrive about 90 minutes prior to surgery. It's already been decided by that point if it's going to be an outpatient procedure or if the patient's going to stay overnight. With partial knees, you can certainly, it can, if there's no other health factors, the majority of patients can actually go home the same day. Biggest thing is not to have anything to eat or drink the day of surgery that morning, not even coffee. And then you'll see the surgeon or myself in the pre-op holding area where we can answer any last minute questions. We will mark the site. The patient cannot go back to surgery unless there's our initials on the site of the surgery. And then at that point you meet the anesthesiologist and they will discuss, different options for the anesthesia. And typically a peripheral nerve block is recommended. And then there's general and spinal anesthesia depending on the patient's preference. And of course, the pre-op nurse will check the patient in, take vital signs, start an IV, and make sure there's any other concerns or questions that they have with regards to the patient prior to going back. Surgery itself, like I said, it can be outpatient versus inpatient. Typically, that's decided when we schedule the surgery, and that depends on the patient's health and desires. Surgical time itself is really not that long. It's typically about an hour procedure. Usually the patients are in the post-op recovery area for about an hour. And then that's when physical therapy, if they're going home the same day, will come in and work with the patient and make sure that they're cleared to go home that same day. I do recommend an ice machine if you're going to be doing really any surgical procedure, but certainly with knee surgery, ice machines can be very helpful in that first 2 to 4 weeks. Some people ask what CPM, which stands for continuous passive motion machine. Studies show that you really don't need those nowadays. That doesn't really change or benefit as far as the range of motion. Some patients want them, and that's totally fine. It really doesn't cause any harm, but the studies do show that they're really not that beneficial in most of the procedures that we do. And then recovery, it really starts the day of surgery. Patients start walking that same day, start moving the knee that same day. Typically, outpatient physical therapy is between 6 to 12 weeks of therapy, depending on how the patient's progressing. Obviously, things that they're working on right away is gait training, working on how to learn to walk again, working on range of motion. And by 3 months, most patients with partial knee replacements are getting back to pretty much full activities. I used to restrict on what patients can do after surgery, but the way that the materials are made now and how strong they are, there's really no restrictions. I have a patient that had both of his knees replaced with partial knee replacements, and he's out doing ultra marathons and doing those type of activities. Um, you know the you know complications. I mean, there's certainly anytime we do surgery, there's always risk. There's risk of infection. Less so in partials than totals. I'd say on average it's about 0.5%. With total knee replacements, it's between 1 and 2%. We always give antibiotics before surgery. And if you stay overnight, we typically give antibiotics overnight as well. The risk of blood clots with any type of knee surgery is prevalent or is present. But again, with partial knees, since people are up and moving around quicker and faster, that risk is less. Scar tissue development or stiffness, it can happen, but again, rarely in partial knees versus total knees. And then the biggest question patients ask is what happens, what happens if my knee starts to have arthritis in other parts? And that can happen, but in my experiences, and actually in the literature as well, usually by 10 to 15 years, The survival rate for the partial knee is about 95%. That means only about 5% of people typically have to get it converted to a total knee. And if it does have to be converted down the road, it's not that complicated of a procedure for it to be converted. Um, so I think in summary, partial knees are a great procedure. They're some of my happiest patients. I think the indications now, we're expanding them more and more. We're doing them on younger and younger patients. I've done them on people as young as 30. Um, it's a less invasive procedure. It's a faster recovery. And I think with robotic surgery, which is definitely the future, that's going to continue to expand and be improved upon. I think it's the way to go. Um, and I think, people that want to get back to an active lifestyle, I think this is absolutely a procedure that does well. So that's my talk. Kept it under 30 minutes. So I don't know if people have questions or not. I can't see the screen, so I don't know.
I'll jump in. That was great. Thank you so much. We
Okay.
do have a couple questions, and I'll just remind you if you do want to ask, you can ask in the chat, or there should be a Q&A box located at the bottom of your Zoom screen. Um, but the first question is just asking about how long these replacements last. Do you have to go back
Yeah.
in?
Yeah. So that's a great question. The materials that we're using now, the weakest link on any joint replacement, whether it be hip, knee, or shoulder, is the plastic component. Over time, that plastic component can wear out. And nowadays, with these implants, we're using what we call highly cross-linked plastics, and they're improving on that plastic all the time. And so the plastics that are used today, obviously, they don't know how long they last in real life, but in the laboratory setting where they test them, they're lasting between 15 and 20 plus years now for partial knees.
There is a question about if you can talk about a location in Reno that's doing knee replacements with with custom fits. Not sure of the name, but
So there, yeah. So there's just kind of what I think what they may be alluding to is there used to be they do what they call a conformis. There's a company called Conformis, and that was where you get a CT scan of your knee, and you actually get custom jigs that you use in surgery to make the cuts. It's not robotic surgery. It's more custom, basically cutting blocks that you place on the knee to make the cut. Um, as far as custom implants, there's really nothing out. You don't really have custom implants made specifically for patients unless there's some kind of significant deformity or abnormality that standard type of implants can't correct. But the thing that with the Makoplasty that's nice is with that CT scan, I can actually perform the surgery before I even do the surgery. I can change the size of the implants, look at how much cut I want to do, and look at the balancing of the ligaments before I do anything. And so I think that that is pretty amazing. And but I'm not sure what they mean by custom knee replacement. The only thing I can think of is the conformist.
sure. And if you want to elaborate in the chat, I'm happy to ask a follow-up question. Um,
Sure.
the next question is asking about how you evaluate patients with knock knees, bow legs, or rotational deformities.
Yeah. That's a great question. I think the best thing, that gives us the best look at the overall uh, limb is getting what we call long leg films, standing films, and that gives us from hip down to ankle. And that can really show us how significant the deformity is, at least from the skeletal standpoint. And that's where with robotic surgery, as far as if you have severe deformity, severe knock knee, or severe bow leggedness, you are not typically a candidate for a partial knee because the problem is you can't correct that amount of deformity with just replacing part of that one component of the knee. And so if you only did a partial knee on someone that has severe deformity, what happens is you haven't corrected that force or that alignment, and that puts a lot of force on that replacement that you've done. And so they have a significant higher failure rate if you just do that in someone that has severe deformity. So those patients are more candidates for a total knee because of the fact that we can correct that deformity better by replacing the whole knee. And that goes along with rotational deformity as well.
Are there activities you personally discourage after a partial knee or full knee replacement?
I used to be, when I trained, in my residency back in the early 2000s, you would tell people not to run on these implants. You would tell people not to do any kind of high impact type of activities. I don't, I don't limit patients now on those things. I think I think I do tell patients that typically, if you're going to do things like running or any kind of other high impact type of activities, you have a higher chance of wearing out the plastic sooner, whether that be, you know, a couple years sooner than what it would if you didn't. That's all I give is that caveat, but I don't discourage it anymore. I think obviously most people that live in this area, they want to be active and do things outdoors and do, some of these higher level type of activities. And so you can ski, you can snowboard, you can mountain bike, you can run. You can get back to those things.
Talk to us about weight loss. Do you need to lose a lot of weight before a knee replacement?
Yeah, that's a great question. And if you think about it, like if you think about like sometimes weight loss is all you need. Like I've had patients that come in with severe arthritis and being overweight, and they're symptomatic, and they go and on a weight loss program and end up losing weight. And then they actually don't even something. They come back and they go, my knee does not bother me that bad. And so if you think back on that diagram that I showed, when you're walking, you're putting 3 times your body weight. So let's say you weigh 200 pounds, that's 600 pounds going across the knee every time you take a step. If you just lost, let's say you lost 20 pounds, I mean, that's taking a significant amount of force across that joint every time you take a step off. So I think weight loss is important. I mean, there's cutoffs that we kind of look at, BMI of 40. And the studies have shown that above that, there's higher risk of complications, certainly things like infection or wound complications. And so we encourage that. But I get it too. I mean, it's hard to exercise, it's hard to lose weight when you have significant joint pain. But nowadays, there's definitely things that are out there that can assist in weight loss things, obviously not just exercise and obviously good nutrition, but there's medications and stuff as well.
And there is a follow-up question, just I think asking about from maybe the bigger question is like what question should you be asking when choosing your orthopedic surgeon for a procedure like this? And maybe just touch on like the pros and cons of robotic versus the surgeon, him or herself.
Yeah. Well, I think like in anything, you know, with a with patient and surgeon, I think it's important to have a good rapport with the surgeon that's going to be doing the surgery. I think it's important to it's always good to know what the experiences is. Not to say that someone with less experience isn't good, but I mean I think it's just looking at their training, that's important. Knowing how many, I mean, it's never hurts to ask the question of, how many of these have you done? I mean, that's always a good place to start. Um, as far as with, you know, robotics, um, the robotics is not doing the surgery. It's still the surgeon doing the surgery. The robot is really just assisting. It's helping with assisting with the cuts and the preoperative preparation, and planning. But the surgeon is still making the decision how much to cut, how much, what's the balancing, all the different technical factors that go into that. That's still dependent on the surgeon. So I think volume's important. I think experience and and then again, rapport. I think it's important to have a good rapport with the person that you're going to allow to do surgery on you.
Another question, how do knee replacements interact with hip replacements, which in this person's case, they have both?
Um, that's a great question. As far as, you know, it's important, with looking at the overall alignment. If someone's had a previous hip replacement. I mean, it's certainly important to make sure that one, their alignment is good. And when you're, proceeding with either a partial or a total knee replacement, kind of keeping that in consideration. If it's vice versa, knee replacement and going on to hip replacement, kind of the same thing. A lot of times too, patients that have had previous knee replacement and they start having increase in knee pain after the replacement down the road. It comes to find that if you get an x-ray of their hip, a lot of times they have hip arthritis, and patients that have hip arthritis, they can get referred pain to their knee. So that's something to consider, that in patients that had previous knee replacements and they're starting to have an increase in their knee pain and they had their knee replacement years ago, it's something to think about, looking at their hip.
Great. And I think this is the last question, but if another one gets asked, um, let's see. Oh, there was a follow-up question about that. What do you mean by alignment of hip?
Well, I mean, if you look at, if you look at if you look at your limb in as a whole, there is, an alignment that you are trying to, ideally get to. And typically we have, it's kind of hard without just drawing it, but most people's femurs kind of come in and then the knees kind of go like that. And so if they've had hip replacement, sometimes that alignment can be changed a little bit with the surgery. And so you just want to look at it overall, is that alignment affected and how does it's going to affect when you're planning to do the knee replacement? And that's it.
Okay.
Hope that answers it. I don't know.
Yeah. And then the last question I'm seeing is what's the youngest patient you recommend for this? And I think we should also ask, like, is there an age limit that you would recommend?
Yeah, that's a great question. There are other, if you have isolated, arthritis to one of the compartments and you're young, there are other procedures that are out there that is not partial knee replacement. But it used to be we kind of didn't do partial knee replacements on anyone younger than, it used to be 50. That's kind of that was just a kind of a generic cutoff. But the problem is, patients that are 30 and 40, that want to be active, they can't be. And these other procedures, I'll just throw out the other one is what we call an osteotomy, where we actually cut the bone and realign the leg to take weight off that area that's affected. Those are big procedures and it does change the overall alignment, and it doesn't take away the arthritis. It just changes where the weight is going across that joint. And in my opinion, I mean, this is certainly a personal opinion, and I've done lots of those type of procedures as well. It's just they don't last as long. It's a big recovery, a bigger surgery, and then down the road, you still end up needing some type of replacement. And so I don't have a cutoff on age. Like I always tell my patients is, I mean, you may be 40 years old, but you have a 75-year-old knee. And so with the way the implants are designed now and how strong they are and how durable they are, I don't have an age restriction. I mean, I think the youngest has been that I've done is 30. And what I tell people is this may give you a knee for 15 years and then you may have to revise it. But if I told you I could give you a knee that's good for 15 years and you can go and do things like ski, cycle, maybe even run a little bit, or hike and enjoy the outdoors, and you get 15 years out of it, and then you have to convert it to a total, would you take it? And most people would say, yeah, I would take that.
Um, I think going back to maybe the hip question, but just or in general, what about one leg that's longer than the other for knee replacements?
Yeah. really with with hip replacements, that's kind of the one of the biggest complaints that patients have is what we call limb length discrepancy. And that's hard. I mean, with the robotics now, we can actually correct that pretty easily with doing hip replacements. We can kind of dial in what the difference is, and we can kind of on the computer we can kind of figure out what the cut's going to be and all that stuff. With doing knee replacements, whether a partial or total, you really can't correct for um, you know, limb length because you're making the cuts based on the balancing of the ligaments that are in the knee at the time. And so you can't make someone longer on that knee because it would stretch those ligaments and you would lose significant motion if you put in a knee that's too tight by trying to correct for a leg length discrepancy.
Okay, I think we got them all. Dr. Swanson, do you want to just share where you practice out of so if anyone
Oh
wants
yeah.
to get in touch?
Yeah, so I practice in South Lake Tahoe at our orthopedic wellness center. I'm there on Thursdays, and then I'm down in clinic on at our Carson office on Tuesdays, and I do surgeries up here on Wednesdays and surgeries down in Carson Valley on Mondays. And I do go to clinic a couple times a month down in Gardnerville as well. But yeah, I'm kind of split 50-50.
Great. Well, thank you so much for taking all the time. I thought there were some great questions and it was a great
Yeah,
overview. If you want to, like I said, go back and watch this later, we'll have it on our YouTube channel. We'll put it up on our Facebook page. And we also have a survey at the conclusion of tonight's webinar that we love to get your feedback. How'd we do? And what topics do you want to hear from us in the future? Thank you, Dr. Swanson, for being here. I hope everyone has a great night.
awesome. Thank you very much, Natasha, and thanks everybody for joining.
Have a good night.
Bye bye.